Hi, everyone. Oh, it is such an honor to be with this team and to be able to talk to all of you this morning. So my title is a bit of a deeply nerdy inside joke about adjuvant surgery because there really is no such thing. And this term was coined by one of my favorite mentors, Dan Coit, from Memorial Sloan Kettering in 2017. It will surprise you that surgeons very arrogantly think surgery is the only tool in the toolbox. And so for many decades, that was the mainstay of how we treat this disease, and everything else is the adjuvant. And with the advent of immunotherapies and some of the things that I'm going to talk to you about, that script has finally flipped. And anyone who knows me well knows that one of my career goals is to eliminate my job. And so I want to talk to you about why I think that's going to be possible in my lifetime. And so the mainstay of the type of immunotherapy that we mean here is medication class called checkpoint blockade therapy. And with this therapy, it has just changed the way we not only treat melanoma, but how we even think about what cancer is. And until this drug class became available, surgery really was the only thing we had to offer. And so when I was asked to talk about what's new in surgery, my answer was very little change about surgery. Barbaric. It's been the same as long as we can think of it. But this is what has changed and how we approach surgery and when we need to use surgery. Because when we talk about adjuvant therapy, the standard nomenclature is that surgery comes first and then adjuvant therapy are the medications that we add afterwards to prevent the disease from coming back in the future. And so this medication was the first to show us that after surgery, we could improve survival and we could truly make a difference in the outcomes for the disease. And so the NCCN guidelines, which all of us use to guide our care for patients, have rapidly changed already once in my career, which is why I'm able to conceive of these things changing again and again for us, such that when I gave a talk very similar to this, even just a year and a half ago, the guidelines said that we could consider in the context of a clinical trial, we should really think about using these medications first. But it certainly wasn't standard, whereas now, in just a year and a half, this is accepted as the mainstay of our frontline approach for patients that present with advanced disease or have melanoma already in their lymph nodes when they come to us. And so this is what it looks like when your melanoma doctors get excited. The medical Twitter just exploded with these trials, and I highlighted some quotes that this was just incredible. Their minds are blown, game changer. You could truck through these curves, and my friends, talked about this over and over again because those of us in immunology had always thought that giving the medication first should work better, but we finally had the evidence with this trial. So just to briefly tell you about the science of why we think this should work better. These checkpoints are molecules on the surface of tumors and immune cells that turn the immune system off. And the analogy we frequently use, they're like the brakes on, so that when these molecules are engaged, that the immune cells stop working effectively. So when we bring these drugs in, these checkpoint blockade drugs in, they take those brakes off so that the immune system can return to attacking those tumors. Now, unfortunately, that's a non-specific process. So it comes with the side effect of then activating your immune system all over your body. And you can have what we call immune-related adverse events that can affect anywhere in the body, really. And so the balance is trying to judge how do we get the maximum impact on your immune system without causing these side effects. And so that's when we talk about the rationale of using the medication up front. Because historically, with chemotherapy, we thought that, with chemotherapy being toxic to most cells in the body, that ideally we should remove as much of the tumor as possible. And by leaving only a little bit of tumor to attack, we can use less chemotherapy. But with immunotherapy, we want that tumor intact so that your body can learn to recognize that melanoma and in effect become vaccinated against it, if you will. And so not only do we think you'll get a stronger immune impact, but it really helps us surgically. It can reduce the size of the disease so that your surgery is smaller and has less risk of having an injury with surgery. And it also gives us important information about how you respond as an individual to this type of therapy. Because if you think about the alternative, where we remove the tumor first, we will treat with a standard 1-year approach, but we really don't know how much impact that's having. And so, we used this in several different iterations with the older classes of this medication. And unfortunately, that side effect profile was too large for us really to implement this in a standard fashion. And so with this new trial that I was mentioning, the SWOG 1801 that's been out for the last 2 years, this had used the current mainstay of therapy, which is a single agent called PD-1, and had properly asked the question by randomizing patients to have surgery either before or after 2 months of therapy, and following them longitudinally and then continuing the therapy for a full course of a year. And the results were impressive. It was very clear that the patients who received the therapy first had a better effect, consistent with what we expected. And what's really important about these curves is you see them flatline. And that's how you know these types of therapies are working, is that the body maintains that memory immunologically. And the important questions then that I get asked in the clinic is, well, what happens if it doesn't work for me? And what are the chances I'm going to have a side effect that's going to be devastating from this therapy? And so in question number 1, the number you want to know is 8%. It was only 8% of patients that did not go on to receive the surgery they expected to have. And what's important in that number is most of those patients actually had a progression of their disease outside of the original surgical field. And so those were patients, we needed to know about that. Those are patients that need to move on to what we call early, some of the other types of therapies that Dr. Bedoff-Warner is going to talk to you about after me, and need to move on to something else other than surgery. And we don't want to waste time using the wrong therapies or taking the wrong approaches. And the other good news was that the side effect profile was fairly low, and it's essentially the same. So whether or not you use the therapy before surgery or after surgery made no difference. And so as Dr. Fontaine alluded to, though, one important consideration is that our imaging hasn't really caught up with this therapy, so that when we look at the PET scans or the CT scans, we may not really know if what we're seeing is immune activation just from being on the therapy, or if it's actual resolution of the cancer. And so to this day, it remains important that we still obtain pieces of that tissue, if not perform the same surgery, because that's probably question number 3, is if I'm having a great response, do I still have to have this surgery? And so far, we think the answer is yes. In particular, so that we can keep learning about who this therapy is for and what it looks like when someone is not a responder. And so overall, the takeaway of this study was that we feel this should be the standard approach for most patients. It is safe, and it is definitely having an impact. And so this has been repeated in other study designs with other agents. This study just came out this summer, the Nadina trial, that goes back to using some of those original drugs, the CTLA-4, just changing up the dosing and changing up the approach. And it's been proven highly effective. So now we have an extra confusing question about which variety of the therapy is going to be best for you. And then there's another class of agents, which is the particular interest of mine, which is giving the therapies directly into the tumors rather than by IV. And so we've run studies using a kind of medication that you inject. Here, this type that I'm describing is actually a virus that infects the tumors preferentially and then causes those tumor cells to break open and release all those antigens, teach your body to recognize what melanoma looks like, and then stimulates an immune reaction that can be persistent in the sites that we don't inject. And so, well, this is imaging from one of our cases at UC Davis. We used this type of therapy in a patient that had a recurrence of their melanoma. You can see an extensive area that would have been very difficult to perform surgically. And so we inject this medication for a number of weeks, and we see here a complete resolution of the tumor. You're actually left with some pigmentation like a tattoo, which can be interesting. But overall, this patient went on to be disease-free for 5 years and never went on to receive the checkpoint therapies and had no side effects from this approach other than the wound care needed in the beginning of the treatment. And so then this is also an example of what that can look like, that abscopal effect, where we see sites that we don't inject respond. So this is a patient that had a neck tumor injected only and also had lung disease. And over the course of a few weeks, we see the lung disease go away as well. Now, unfortunately, that part is not good enough yet. It doesn't satisfy us. It's maybe about 10% of patients that can expect to see all of their tumors go away just by injecting one single site. But we're getting better and better at this with every generation of this drug. And so there'll be more and more trials coming down the pipeline. But we have studied it in this specific scenario, this neoadjuvant scenario. Can we then harness how well this type of medication works by injecting the tumor before surgery and generating an immune response before we ever take you to the operating room? And it turns out the answer is yes. And we saw about 20% of patients have a complete resolution of their tumors before they ever got to the operating room. And so the questions that remain are, which therapy is going to be best? And the answer is we don't quite know yet. Can we avoid surgery? Which I think one day absolutely, but not quite yet. And that can we de-escalate how much therapy you need based on what type of response you've seen? And then this is data from that NADINA trial showing the differences between patients that have had a complete resolution of their tumor versus partial versus a progression. And you can see that the patients that had the response, we know how well they're going to do. Now, the question that remains for me, while I have many wonderful colleagues answering the question of how do we make these therapies better or how do we reduce the side effects, my question is, how do we know what's going to happen to you when you come into the clinic? And, my husband is here today because he can tell you that one of my least favorite responses is, I don't know. And this is an area that we really need to work a lot more on longitudinally studying this tissue before and after the therapy. And so that's what my lab does in collaboration with a lot of people here on campus. So we do two varieties of studies. One is to take the tumors and create many patient avatars that we call organoids. And when we can study those in a dish and give all these same therapies and therapies that aren't going to be available for 10, 15 years and try them in a dish and see what happens. And we can also then manipulate the tumor and change the cells in it and change the way the stroma works and all sorts of features and run many clinical trials in a dish way ahead of what we can do in the clinic. We also work on very novel optical imaging techniques so that we can dive into this tumor tissue in a way that hasn't been done before and classify which molecules are most important in each individual tumor, and then feed all of this information back and forth into the AI and machine learning that we've talked about a lot today, so that we can find even the tiniest signals of what's going to predict what's going to happen for our patients. And so we've started to learn more and more about what the difference looks like between a patient that has a response and a patient that doesn't respond, so that then we can move into the next step, predicting, well, what other therapies should this patient be seeing? And so ultimately, that is our goal, is to create these biomarkers and these tests, and we're coming a long way very rapidly. And, I'm really grateful to many of you who have contributed to this work, and your tumors are in our lab working on this, and we just deeply, deeply appreciate your willingness to help us move the needle on disease.